Anesthesiology, Respiratory Pharmacology in Q&A. Welcome to today's podcast on respiratory pharmacology and anesthesiology, focusing on induction agents, paralysis, reversal, opioids, inhalational agents, and the management of critical scenarios. Let's dive into a comprehensive question and answer session covering 100 essential topics. Pause the video after each question to attempt answer. Let's begin. Question: what is the most consistent and profound respiratory effect of all intravenous induction agents? Answer: intravenous induction agents cause dose-dependent respiratory depression, which results in decreased tidal volume, reduced respiratory rate, and ultimately, can lead to apnea. Question: how does propofol affect the ventilatory response to elevated carbon dioxide levels? Answer: propofol markedly blunts and can completely abolish the ventilatory drive to carbon dioxide. The response curve for carbon dioxide shifts to the right and becomes flattened. Question: how does propofol affect the ventilatory response to low oxygen levels? Answer: propofol suppresses the hypoxic ventilatory response more strongly than the hypercapnic response, diminishing the increase in ventilation that occurs from low partial pressure of oxygen. Question: what advantage does etomidate offer over propofol when inducing anesthesia in a hypovolemic or asthmatic patient? Answer: etomidate causes less hemodynamic instability, which is beneficial for hypovolemic patients, and does not induce histamine release, making it a safer choice for patients with asthma. Its respiratory depressant effects are similar to those of other agents. Question: why is ketamine unique among intravenous induction agents regarding its effects on respiration? Answer: ketamine generally preserves respiratory drive and airway reflexes much better than other agents, though rapid administration or combination with other sedatives can still cause apnea. Question: does ketamine blunt the hypoxic ventilatory response? Answer: no. Ketamine is distinctive in that it either preserves or stimulates the hypoxic ventilatory response. Question: what is the major respiratory risk associated with ketamine? Answer: the principal respiratory risk of ketamine is laryngospasm, as the preservation of airway reflexes increases the likelihood of laryngospasm if the airway is stimulated during light anesthesia. Question: how do benzodiazepine premedications such as midazolam affect respiration? Answer: benzodiazepines cause dose-dependent respiratory depression and act synergistically with opioids and other hypnotic agents, thereby heightening the risk of apnea. Question: what is the primary site of action for intravenous anesthetics that cause respiratory depression? Answer: the medullary respiratory centers in the brainstem are the primary site of action for intravenous anesthetics that induce respiratory depression. Question: what does the term ceiling effect mean in the context of respiratory depression caused by partial opioids such as nalbuphine? Answer: partial agonists have a limit or ceiling to their respiratory depressant effects, meaning that increasing the dose beyond a certain point does not cause further respiratory depression, unlike full mu agonists. Question: what is the mechanism of action for succinylcholine? Answer: succinylcholine acts as a depolarizing neuromuscular blocker by binding to postsynaptic nicotinic acetylcholine receptors, causing persistent depolarization and muscle paralysis. Question: what is the mechanism of action for non-depolarizing neuromuscular blockers such as rocuronium, vecuronium, and cisatracurium? Answer: these agents are non-depolarizing neuromuscular blockers that competitively antagonize acetylcholine at postsynaptic nicotinic receptors without causing depolarization. Question: why is succinylcholine contraindicated in burn patients after 48 hours and in major trauma after 5 to 7 days? Answer: after such injuries, there is a risk of life-threatening hyperkalemia due to proliferation of extrajunctional acetylcholine receptors, which can cause a massive potassium release upon depolarization. Question: what is the primary metabolite of succinylcholine and what effect does it have? Answer: the primary metabolite is succinylmonachylline, which has minimal neuromuscular activity but may contribute to prolonged paralysis in individuals with pseudocholinesterase deficiency. Question: what is the significance of pseudocholinesterase deficiency? Answer: pseudocholinesterase deficiency dramatically prolongs the duration of action of succinylcholine, extending it from approximately 5 minutes to several hours due to impaired drug breakdown. Question: how is pseudocholinesterase deficiency diagnosed? Answer: it is diagnosed by observing prolonged apnea after a standard dose of succinylcholine, confirmed by a dibukane number test. A low dibutane number indicates abnormal enzyme activity. Question. What are the two main drugs used for reversal of neuromuscular blockade? Answer. The two primary reversal agents are neostigmine and sugammadex. Question. How does neostigmine work? Answer. Neostigmine inhibits acetylcholinesterase, increasing acetylcholine concentration in the synaptic cleft, which allows acetylcholine to outcompete non-depolarizing neuromuscular blockers. Question. What must always be co-administered with neostigmine and why? Answer. An anticholinergic agent such as glycopyrrolate or atropine must be co-administered to block the muscarinic effects of increased acetylcholine, which can cause severe bradycardia, excessive salivation, and bronchoconstriction. Question. How does sugammadex work? Answer. Sugammadex is a selective relaxant binding agent that forms a tight 1-to-1 complex with rocuronium, and less strongly with vecuronium, encapsulating the drug and removing it from the neuromuscular junction. Question. What is the major advantage of sugammadex compared to neostigmine? Answer. Sugammadex can rapidly reverse deep neuromuscular blockade, whereas neostigmine is only effective after some spontaneous recovery has occurred. Question. What is a potential serious side effect of neostigmine? Answer. Neostigmine can cause bronchospasm due to increased acetylcholine at muscarinic receptors in the airway. Question. Can sugammadex reverse the effects of succinylcholine or benzylisaquinoline drugs such as cisatracurium or atracurium? Answer. No. Sugammadex is only effective against aminosteroid neuromuscular blockers, specifically rocuronium, vecuronium, and pancuronium. Question. What is the significance of recurization? Answer. Recurization refers to the return of neuromuscular blockade after apparently adequate reversal, often occurring if neostigmine is administered prematurely or if its effect ends before the neuromuscular blocker is fully cleared. Question. What monitoring is crucial for safe use of neuromuscular blockers? Answer. The use of a peripheral nerve stimulator, such as train-up-4 monitoring, is essential to assess the degree of blockade and guide both dosing and reversal. Question. What is the primary mechanism of opioid-induced respiratory depression? Answer. Opioids depress the respiratory centers in the brainstem, specifically the Prebutzinger complex, resulting in reduced responsiveness to carbon dioxide and low oxygen. Question. How do opioids alter the carbon dioxide response curve? Answer. Opioids shift the carbon dioxide response curve to the right, meaning a higher partial pressure of carbon dioxide is required to stimulate breathing, and the curve is flattened, resulting in a smaller increase in ventilation for a given rise in carbon dioxide. Question. Which opioid is most associated with chest wall rigidity? Answer. Fentanyl and its rapid-acting synthetic analogs, including sufentanil, remifentanil, and alfentanil, are most associated with the so-called wooden chest syndrome. Question. How is opioid-induced chest wall rigidity managed? Answer. Chest wall rigidity is managed by prompt administration of a neuromuscular blocker to allow ventilation, and an opioid antagonist such as naloxone may also be used, though this will reverse analgesia. Question. What is the ceiling effect for respiratory depression with buprenorphine? Answer. Buprenorphine, as a partial agonist, has a ceiling effect for respiratory depression, which makes it safer in cases of overdose compared to full agonists. Question. Why is morphine relatively contraindicated in patients with asthma? Answer. Morphine can cause histamine release, which may precipitate bronchospasm in asthmatic individuals. Question. Do fentanyl and its derivatives cause significant histamine release? Answer. No. Fentanyl and its derivatives are not associated with significant histamine release. Question. What is the primary treatment for opioid-induced respiratory depression? Answer. Naloxone, a competitive mu-opioid receptor antagonist, is the primary treatment. Question. What caution should be exercised when administering naloxone? Answer. Naloxone can precipitate acute withdrawal in opioid-dependent patients and may cause severe pain, hypertension, tachycardia, and pulmonary edema. Question. Why might a naloxone infusion be necessary? Answer. Because the half-life of naloxone is shorter than that of most opioids. Repeated doses or an infusion may be necessary to prevent recurrence of respiratory depression. Question. How do volatile anesthetics such as sevoflurane, isoflurane, and desflurane affect ventilation? Answer. Volatile anesthetics cause dose-dependent respiratory depression, leading to decreased tidal volume, increased respiratory rate, and a rapid, shallow breathing pattern. They also blunt the ventilatory response to carbon dioxide and low oxygen. Question: which volatile agent is the most potent respiratory depressant? Answer: all agents are significant depressants, but their effects are generally dose-dependent rather than specific to any one agent. Question: why is desflurane particularly irritating to the airway? Answer: desflurane can cause coughing, breath holding, laryngospasm, and bronchospasm, particularly during induction or with high concentrations, and is therefore not used for inhalational induction. Question: which volatile agent is the preferred choice for inhalational induction, especially in children? Answer: sevoflurane is preferred as it is less pungent and less likely to cause airway irritation compared to isoflurane or desflurane. Question: what effect does nitrous oxide have on respiration? Answer: nitrous oxide causes minimal respiratory depression compared to volatile agents but can produce diffusion hypoxia at the end of administration if supplemental oxygen is not provided. Question: what is diffusion hypoxia? Answer: diffusion hypoxia occurs when nitrous oxide rapidly diffuses from the blood into the alveoli, diluting alveolar oxygen and carbon dioxide, which can cause hypoxemia and hypercapnia if supplemental oxygen is not provided. Question: how can diffusion hypoxia be prevented? Answer: administering 100% oxygen for 5 to 10 minutes after discontinuing nitrous oxide prevents diffusion hypoxia. Question: what effect do volatile agents have on bronchial smooth muscle? Answer: all volatile anesthetics act as bronchodilators, which can be beneficial for patients with asthma or chronic obstructive pulmonary disease. Question: what is the mechanism of bronchodilation for volatile anesthetics? Answer: they depress bronchial smooth muscle contraction, blunt reflex bronchoconstriction, and inhibit vagal tone. Question: what is the first-line drug for acute intraoperative bronchospasm? Answer: inhaled short-acting beta-2 agonists such as albuterol are the first-line treatment, as they act directly on airway smooth muscle. Question: how does epinephrine work for severe bronchospasm? Answer: epinephrine is a potent alpha and beta agonist. Its beta-2 effects cause bronchodilation while its alpha effects reduce airway mucosal edema, making it useful in refractory cases and anaphylaxis. Question: what is the role of ipratropium bromide? Answer: ipratropium bromide is an inhaled anticholinergic that induces bronchodilation by blocking muscarinic receptors. It can have synergistic effects with albuterol. Question: how does magnesium sulfate work for status asthmaticus? Answer: magnesium sulfate is a smooth muscle relaxant, likely functioning by antagonizing calcium influx. It is considered a second-line agent for refractory bronchospasm. Question: what is the mechanism of action of lidocaine in preventing bronchospasm? Answer: lidocaine, administered intravenously or topically, blunts airway reflexes and suppresses the cough reflex, which is particularly useful during airway instrumentation. Question: why must intravenous lidocaine be administered slowly? Answer: slow administration is necessary to prevent toxicity, which can manifest as numbness around the mouth, ringing in the ears, seizures, and cardiovascular collapse. Question: what is the role of steroids such as hydrocortisone in intraoperative bronchospasm? Answer: steroids are primarily used for their anti-inflammatory effects, though their onset is slow. They are crucial for managing the inflammatory component but not for immediate rescue. Question: what effect do atropine and glycopyrrolate have on the airway? Answer: both are anticholinergic agents that induce bronchodilation and reduce respiratory secretions. Question: why is glycopyrrolate often preferred over atropine for drying secretions? Answer: glycopyrrolate has a longer duration of action and, as a quaternary ammonium compound, does not cross the blood-brain barrier, resulting in fewer central side effects such as confusion. Question: what is the primary pharmacological strategy for intraoperative pulmonary hypertension? Answer: the strategy is to reduce pulmonary vascular resistance without causing systemic hypotension. Question: how does inhaled nitric oxide work? Answer: inhaled nitric oxide is a selective pulmonary vasodilator that activates guanylate cyclase in the pulmonary vasculature, raising cyclic guanosine monophosphate and causing vasodilation. It is inactivated by hemoglobin, preventing systemic effects. Question: what is a major toxicity of inhaled nitric oxide? Answer: a major toxicity is methemoglobinemia, where nitric oxide binds to hemoglobin, forming methemoglobin that cannot carry oxygen. Question: How is methemoglobinemia treated? Answer. Methemoglobinemia is treated with methylene blue, which provides an alternative electron acceptor to reduce methemoglobin to hemoglobin. Question. What is rebound pulmonary hypertension? Answer. Rebound pulmonary hypertension describes a sudden increase in pulmonary vascular resistance that may occur when inhaled nitric oxide is abruptly discontinued. Gradual weaning is essential. Question. What intravenous vasodilators can be used for pulmonary hypertension? Answer. Prostaglandins such as epoprostenol are potent pulmonary vasodilators but may cause systemic hypertension. Milrinone, a phosphodiesterase 3 inhibitor, offers inotropic and pulmonary vasodilatory effects. Question. Why is milrinone useful for right heart failure? Answer. Milrinone provides inotropy, increases contractility, and lusitropy, improves relaxation for the right ventricle, while simultaneously reducing afterload by pulmonary vasodilation. Question. Why should vasopressors such as norepinephrine be used cautiously in pulmonary hypertension? Answer. Such vasopressors may be necessary to maintain systemic perfusion pressure but can increase pulmonary vascular resistance via alpha-1-mediated vasoconstriction. Question. What is the role of vasopressin in pulmonary hypertension? Answer. Vasopressin is often the preferred vasopressor, as it causes systemic vasoconstriction through V1 receptors with minimal effect on the pulmonary vasculature. Question. What is the mechanism of flumazenol? Answer. Flumazenol is a competitive antagonist at the benzodiazepine binding site on the gamma-aminobutyric acid type A receptor. Question. What is the major risk associated with flumazenol administration? Answer. The major risk is precipitating acute withdrawal in benzodiazepine-dependent patients, which can result in seizures. Question. Can flumazenol reverse respiratory depression caused by other drugs such as opioids? Answer. No. Flumazenol is specific for benzodiazepines. Question. What is the mechanism of doxapram? Answer. Doxapram is a respiratory stimulant that acts on the carotid body to increase the hypoxic drive and directly stimulates the brainstem. It is rarely used due to significant adverse effects and the availability of superior mechanical support. Question. What is the role of naloxone in the post-anesthesia care unit? Answer. Naloxone is used to reverse opioid-induced respiratory depression and sedation, and should be titrated in small doses to avoid complete reversal of analgesia. Question. What is postoperative residual curarization? Answer. This refers to muscle weakness from residual neuromuscular blockade in the post-anesthesia care unit, which increases the risk for pulmonary complications. Question. How can postoperative residual curarization be prevented? Answer. By using quantitative neuromuscular monitoring to ensure a train-up-for ratio greater than 0.9 and administering appropriate reversal agents. Question. What drugs can potentiate neuromuscular blockade? Answer. Aminoglycosides, magnesium, local anesthetics, and volatile anesthetics can all potentiate neuromuscular blockade. Question. How would you induce anesthesia in a patient with a full stomach and asthma? Answer. Rapid sequence induction using propofol, if the patient is hemodynamically stable, or ketamine if unstable, and rocuronium for neuromuscular blockade. Drugs that release histamine, such as morphine or atracurium, should be avoided. Question. Why is succinylcholine a good choice for rapid sequence induction in asthmatic patients? Answer. Succinylcholine has a rapid onset and does not cause histamine release. Question. Why might you avoid succinylcholine in a critically ill asthmatic individual? Answer. If intubated and critically ill for more than 48 hours, such patients are at increased risk for hyperkalemia due to succinylcholine. Question. How is an asthmatic patient managed pharmacologically during anesthesia? Answer. Volatile anesthetics are used for their bronchodilating effects. Histamine-releasing drugs are avoided. Inhaled albuterol is kept on hand, and intravenous lidocaine may be considered to blunt airway reflexes. Question. What drugs can trigger bronchospasm? Answer. Beta blockers, neostigmine, morphine, and desflurane can all trigger bronchospasm by various mechanisms. Question. How does beta blocker therapy cause bronchospasm? Answer. By blocking beta-2 receptors in bronchial smooth muscle. Beta blockers leave cholinergic tone unopposed, which leads to bronchoconstriction. Question. What is the treatment for beta blocker-induced bronchospasm? Answer. Administration of an anticholinergic agent such as ipratropium or glycopyrrolate, and in some cases, high-dose beta-2 agonists may overcome the blockade. Question: what is the differential diagnosis for bronchospasm after anesthesia induction? Answer: mechanical causes include endobronchial intubation, tube kinking, and secretions. Pharmacologic causes include anaphylaxis due to muscle relaxants or antibiotics and direct irritation from the tube. Underlying disease such as asthma or chronic obstructive pulmonary disease should also be considered. Question: how can deep anesthesia help with bronchospasm? Answer: volatile anesthetics are potent bronchodilators. Increasing the level of anesthesia is a primary treatment for intraoperative bronchospasm. Question: what is the role of a helium-oxygen mixture for airway management? Answer: helium is less dense than nitrogen and can reduce turbulent flow and lower the work of breathing in cases of severe upper airway obstruction or status asthmaticus. Its role intraoperatively is limited. Question: how is high-dose ketamine useful in status asthmaticus? Answer: ketamine acts as a direct bronchodilator and can be used as a sedative for intubation in refractory cases outside the operating room. Question: what does silent chest mean in the context of asthma? Answer: silent chest refers to the absence of wheezing due to such severe airflow obstruction that wheezing disappears, signifying imminent respiratory arrest. Question: how does acidosis affect the action of neuromuscular blockers? Answer: acidosis potentiates the effect of non-depolarizing neuromuscular blockers, prolonging their duration of action. Question: how does hypothermia affect the action of neuromuscular blockers? Answer: hypothermia enhances and prolongs the action of both depolarizing and non-depolarizing neuromuscular blockers. Question: what effect do volatile anesthetics have on the duration of neuromuscular blockade? Answer: volatile anesthetics potentiate non-depolarizing neuromuscular blockers, reducing the required dose and prolonging the duration of blockade. Question: why is Sugammadex dose dependent? Answer: the dose of Sugammadex is based on the depth of neuromuscular blockade. Deeper blockade, such as post-return of spontaneous circulation, requires a higher dose than moderate blockade. Question: can Sugammadex be used in a patient with an allergy to rocuronium? Answer: no. Sugammadex is contraindicated in patients with an allergy to rocuronium as it may potentiate the allergic response. Question: what is the significance of phase 2 block with succinylcholine? Answer: after large or repeated doses, the block may shift from a depolarizing to a non-depolarizing character, which may be partially reversible with neostigmine. Question: how does magnesium sulfate affect neuromuscular blockade? Answer: magnesium sulfate potentiates both depolarizing and non-depolarizing neuromuscular blockers by reducing acetylcholine release and decreasing sensitivity of the postjunctional membrane. Question: what is the effect of renal failure on neuromuscular blocker pharmacokinetics? Answer: vecuronium and rocuronium are eliminated in bile and urine, and their duration may be prolonged in renal failure. Cisatracurium is preferable as its metabolism is independent of organ function. Question: what is the effect of hepatic failure on neuromuscular blocker pharmacokinetics? Answer: vecuronium and rocuronium are primarily metabolized by the liver, and their duration will be prolonged in hepatic failure. Question: why is cisatracurium recommended for multi-organ system failure? Answer: cisatracurium undergoes Hofmann elimination and ester hydrolysis, making its clearance independent of renal or hepatic function. Question: what effect do opioids have on the cough reflex? Answer: opioids suppress the cough reflex, which can be beneficial during awake intubation or emergence from anesthesia. Question: what is remifentanil-induced hyperalgesia? Answer: remifentanil-induced hyperalgesia is a phenomenon where the use of this ultra-short-acting opioid leads to increased pain sensitivity post-operatively, necessitating higher than normal opioid doses. Question: how does dexmedetomidine affect respiration? Answer: dexmedetomidine causes minimal respiratory depression and is an excellent sedative for procedures requiring spontaneous ventilation, such as awake fiber optic intubation. Question: what is the role of nebulized lidocaine for airway anesthesia? Answer: nebulized lidocaine provides topical anesthesia of the airway and blunts reflexes during awake fiber optic intubation. Question: why must the total dose of topical lidocaine be carefully monitored? Answer: the airway is highly vascular and rapid absorption can occur, increasing the risk of local anesthetic systemic toxicity. Question: what is the mechanism of action of dantrolene for malignant hyperthermia? Answer: dantrolene inhibits calcium release from the sarcoplasmic reticulum in skeletal muscle, essentially uncoupling excitation contraction. Question: which inhalational agent is the most potent trigger for malignant hyperthermia? Answer: all potent volatile agents, especially halothane, followed by sevoflurane, isoflurane, and desflurane, as well as succinylcholine, are potent triggers for malignant hyperthermia. Question: what is the definitive treatment for a malignant hyperthermia crisis? Answer: the definitive treatment is to stop all triggering agents. Administer dantrolene at 2.5 mg per kilogram intravenously and repeat as needed. Provide supportive care including hyperventilation with 100% oxygen, cooling the patient, and treating hyperkalemia and acidosis. Thank you for listening to our podcast. We hope these 100 questions and answers provide clarity and insight into the complex world of respiratory pharmacology and anesthesiology. If you enjoy the content, please like, share with a friend and subscribe for future content. It's the Everything Surgery Podcast. Dissect the extraordinary.